Good afternoon and welcome, everyone. My name is Robin Buxbaum. I'm the Strategic Partnerships Coordinator here at ACHA. This is our 8th ACHA COVID-19 webinar discussion, and today we are expanding upon the topic of contact tracing as covered in the ACHA reopening guidelines. If you missed any of our past webinars, recordings are available on the ACHA YouTube channel. This week's webinar will be the last for a while as we turn our attention to our new event, the ACHA COVID-19 Summit on July 28th and 29th. The summit will be a virtual event and will run from 12:30 to 4:30 on both days. We'll be releasing more information soon about that, so please stay tuned. Back to our presentation today. At any time, feel free to type a question into the questions pane on the right side of your screen. We do have a lot of information to get through today, so while we'll try to leave time for questions, we may not get to many. We do review that list after each webinar and have been using those questions to guide us in our work. One last item, those registered will receive a link to a recording of today's presentation, so feel free to share that with colleagues. With that said, let's get going. I'm pleased to introduce our three speakers today. Ashlee Halbritter is a public health professional currently serving as the Senior Director of Campus Health at the University of Pennsylvania. She was recently elected Chair-elect of ACHA's Health Promotion Committee. Before making the move to College Health, Ashlee worked for the CDC. Jason Feldman currently serves as a Policy and Performance Management Coordinator at the Washington State Department of Health, where he conducts COVID-19 case investigations and contact tracing. He previously worked for the Oregon Public Health Division, assisting in legislative efforts to restrict chemicals in commercial products. And prior to that, Jason worked for the Florida Department of Health on cancer registry data. Jason also completed the CDC Health Prevention Service Fellowship. Nguyen is a family physician and public health professional. He serves as the Executive Director of Harvard University Health Services and is the Henry K. Oliver Chair of Hygiene at Harvard University. He also serves on the Board of Directors of the American College Health Association and is a member of ACHA's COVID-19 Task Force. Formerly, John was Executive Director of the Student Health Service at the University of Pennsylvania. So first of all, welcome to everyone and thank you for joining us. I am going to turn it over now to Ashlee to kick us off.
Hi everybody, here's an overview of the things we'll be covering today, a little bit of background about contact tracing, things to consider when staffing for contact tracing, how to monitor and assess your contact tracing efforts, and then some tips, tricks, and guides related to case interviews and notifying contacts. Next slide. I'm going to pause quickly here and just say that this presentation is very word heavy. That's purposeful because we wanted to help define language and be as descriptive as possible. We will skim through some slides to ensure enough time for questions at the end. There are additional slides that we will not review today that are available to you as part of the slide deck that has already been shared. We really wanted this presentation to be a reference guide with scenarios and examples for people to look to, even if we don't get a chance to review all of them today. The second piece I want to mention is that we created this presentation with the understanding that testing was happening at your institution and that you had access to those results. Testing is the first step for contact tracing. So I just wanted to be clear that that was sort of the baseline understanding under which this presentation was created. Next slide. Starting out with common definitions. So in this presentation, a case is a patient with lab-confirmed COVID-19 or SARS-CoV-2. Case investigation and case interview are used interchangeably in this document. The most common term is case investigation. But at some institutions, like at mine, investigation scares people a little bit, so we sometimes say case interviews. But a case investigation is a conversation with a case to assess symptoms, activities, health history, etc. It's also important to recognize that isolation and quarantine are technically different. So isolation is the separation of sick people that have a contagious disease. Isolation guidance related to COVID-19 does continue to change a little bit, but currently is a minimum of 10 days. After that, including an improvement in other symptoms and at least 3 consecutive days of no fever without the use of fever-reducing medications. Next slide. Contact is a person who may have been within 6 feet of a case for 15 minutes or longer. That is another example of a guideline that has changed recently. CDC updated that this week. For a symptomatic case, that can be 48 hours before symptom onset until isolation. And for an asymptomatic case, the contact could be up to 10 days prior to the positive specimen collection. Contact tracing is the process of collecting information about symptoms, illness, and activities from persons identified by cases as contacts. It's really important that you always protect the privacy of the case and contacts, and we will talk more about that in the next section. And I had already said that isolation and quarantine are different. So for quarantine is about separating and limiting the movement of people who may have been exposed to an illness. And right now that guideline is 14 days from date of exposure. Next slide. Jason.
Thank you. So the Washington State Contact Tracing Initiative has been launched since March. On Wednesday of this week, the governor put out an update on it. This is one image from the recent update, and this outlines the process of contact tracing, beginning with identifying cases, interviewing those cases, through that process, eliciting their contacts, close contacts, which we'll talk about, and then emphasis here with repetition on confine those who are exposed. In an ideal Washington state and beyond that, testing would be very easily available and abundantly available. Testing capacity has greatly improved since February. Most people who are being tested by way of a drive-through outdoor testing site. And again, emphasizing, in the words of our governor, the stay home, stay healthy initiative. Stay home until it's safe, whether it is 10 days without fever, improvement in other symptoms for cases, or 14 days for identified contacts. So all of this takes a lot of resources. As of Friday, May 29th, an estimated 1,370 contact tracers have been trained, including, throughout the month of May, a contingent of National Guardsmen of approximately 350. So I'm going to focus less on that, but more so on some of the steps that go into each of these 5 identified elements or components of the contact tracing initiative. Next slide. Great. So this outline emphasizes 3 aspects of a hub and spoke approach that was beautifully described by Illinois Governor J.P. Pritzker on May 1st at a press conference, and we're using the same one here in Washington, and I know other jurisdictions are as well, where the cases are investigated, contact tracers follow up on identified contacts, and then resource coordinators are available to support individuals who are either in self-isolation or quarantine to ensure that they have a safe place to stay away from other people during the duration of time of interest, to ensure that they have groceries, to ensure that they may be moved into alternate housing if that's an issue. So that is the hub and spoke approach that I will be referring back to. And in the case of the local assets in Washington State is a home rule state where there's a lot of autonomy and responsibility placed on the local health jurisdictions. So we at the state are supporting states who have asked for our help, and we are forwarding all the information that we collect in our investigations to local partners who then follow up with confined folks. Next slide, please. Okay. So one of the things that I really emphasize when I'm on the phone with people is that this is a new disease, and all of the information that we're asking in our questions will be extremely helpful in helping us understand this new disease better and to prevent future cases. We want to stop the spread of this outbreak. And I think that's pretty clear. I will describe the interviews themselves. They really focus on 5 main areas, including symptoms that a patient or contact may be experiencing, recent activities, a health history, and then the public health guidance about staying home, about avoiding contact. So asterisks after public health guidance. And then fifthly, eliciting contacts. So I just wanted to point out that, look, these are real people in real places. And there's a lot of jargon that oftentimes is used that may not transfer all that well, including the language around non-pharmaceutical interventions. The non-pharmaceutical interventions currently are to please self-isolate and quarantine. Next slide. So this is the main point that so far has been highlighted by Ashlee and I, and we will be referring back to this. Next slide. Okay, so I was mentioning real people in real places. We're asking people to not go outside. In the case of Martin, who tells me that, yeah, he's still sick and his doctor told him to stay home until the 1st of June. That also means that his household contacts, his spouse and or children, are then supposed to wait until June 1st to quarantine themselves for 14 consecutive days. And that's a challenge. It's not healthy for us to be cooped up like this. So this is a reminder to us that risk is a spectrum, and there are ways to mitigate risk. And I want to emphasize public health mitigation as a harm reduction model where we hopefully meet people where they are from a non-judgmental place in an accessible way. So with that, I'm going to hand it over to John.
Thank you. So I'm going to talk a little bit about staffing and how we can pull together a team to do the work that we need to do. Next slide, please. The most important thing to begin with is making sure that the folks who are doing this have the right knowledge and skills. And some of these are include knowledge that you can build, such as what the implications are for confidentiality, what the rules are, how do you have a conversation with a close contact without violating confidentiality, what are the medical terms and how do you use them correctly, and how do you refer to medical concepts without using jargon. All of this is very important as you consider how you train the staff who are doing this. And I think that if you are using health center staff, many of us are already familiar with many of these things. The interviewing skills are a big part of doing appropriate and effective case investigation, and that means building trust, building rapport, having those interpersonal skills, and also the emotional and cultural sensitivity to work effectively. So if you know the population you're working with well, you're able to develop that rapport more effectively. Next slide, please. There are also some additional skills that are a little bit more higher level, and some of it includes some basic crisis counseling. Because if you're talking to someone about the fact that they're now infected, or the fact that they have been potentially exposed to an infection that is very scary, there is the likelihood that you will be encountering a high degree of anxiety. And so the crisis counseling is an important part of this. In addition, someone who is working in this area needs to be thinking about the resources that your clients might need, and being able to understand what resources exist. So on a campus, this includes things like delivery of meals, or making sure that someone has assistance with laundry or other types of things. All of that is really important. What, do they have all the things they need, like towels or the basic toiletries? All of these things are important. And also just important for people who, if you're using non-clinical staff, for them to understand when to refer things beyond to a clinical specialist to evaluate further. And I emphasize the cultural competency. It's a very important piece of what we're doing. Next slide, please. Specialized knowledge. So if you're going to be working with residence hall communities, understand what the different houses are, what the names are. If there are important features about this that you need to understand. If you are also working with folks who perhaps are going into research labs, or students who are in clinical training programs, or maybe you're doing contact tracing that involves faculty and staff in addition to students. Does this include trade staff and other essential staff, contract workers and contingent workforce who might be part of your campus community but not officially employed by the university? It's important to be thinking about all of this and being prepared. And as I mentioned before, understanding what all of those resources are for the people that you're going to be working with. Next slide. So Ashlee mentioned a little bit about privacy before, and I'm going to reiterate the importance of that, and also the importance of information security. You want to make sure that your team is trained about the importance of privacy. There should most likely be some type of signed confidentiality statement for if you're adding non-health center staff. So presumably your health center staff will already have done this. Sharing of information should only be done to for those who need to know, and the minimum necessary information should be shared with administrators and so on if things are requiring their involvement. Also keep in mind that your data should be stored in a safe and secure location, whether it's physical data or electronic. So if you're having it on paper, it needs to be in an office that is lockable. If you have data that's electronic, it should be password protected. Consider engaging with your privacy office if your university has one, or the Office of General Counsel or Information Security. Next slide. Also consider, especially now when we are working from home a lot, we should be thinking about the environment in which we are making these phone calls. It has to be a private space, avoid interruptions, minimize risk for eavesdropping by anybody who might be in your household or in the place where you're working. So you might consider using a headpiece, an earpiece, or a headset. Remember that this is a high anxiety conversation for many of our clients. And so if you suddenly hear an interruption or something like that, it's going to influence the rapport building and the sense of safety that these folks have in the conversation. When you speak with cases, make sure that you are clear that the information will be kept confidential, and that any close contacts who are identified are not going to know the name of who the case was. And also when you speak with the case, the close contacts, basically you're sharing the date of exposure, the expected date of quarantine completion, but you should not reveal the identity of the person who was sick. Next slide. Okay. Benchmarking and estimating of how many people you need. This is really hard to do because it has a lot of assumptions that come into play. So right now in Massachusetts, the Department of Health has engaged 15 contact tracers for every 100,000 population, but this is not a magical number. Different places have used different ratios. In New Zealand, it was 4 per 100,000. In Iceland, it was 7 per 100,000. Washington State just recently announced that they were doing a similar program to what Massachusetts has done, and I did some back of the envelope calculations, and it sounds like about 19 per 100,000 there. But in Wuhan, China, they used 81 contact tracers per 100,000. So one of the things that that you need to think about is how many positive tests do you think you'll be learning about on a daily basis, and from there you can do your calculations. And I've added a number of bullets for your consideration here, but I'm not going to read them aloud to you. Next slide, please. Okay, so how do you find people to do this? Certainly redeployment of staff from your student health clinic, your university health center. This is a good place to start. As well, including people from your counseling center, if they have the capacity to assist. Perhaps folks from the health promotion office, which often includes people who are trained in public health. And then there are other areas of the university that you might consider. But different institutions will have different levels of comfort about involving people outside of the health center. So it's important for you to think about some of the optics and how your community will respond. There's also the possibility of using students to do this work. For example, students in public health, nursing, medicine, and so on. Again, this really depends on the level of comfort that your institution has. And if you are going to be using students to do this, there will need to be some very specific safety measures in place to ensure that that privacy is carefully monitored. And some places have also used alumni to assist in this process too. So these are just a few options. Next slide. All right, I will turn it over now to Ashlee to talk about data monitoring and assessment.
Thank you. Next slide. So this section's going to get into a little bit more of the nitty-gritty of how you collect data, but then also how you assess it. So where and how are you collecting? Certainly there are options to use pen and paper. You could use the electronic medical chart that you have available at your institution. Your COVID planning task force or your emergency management team at your institution may have software that's worth looking into. Local applications like Excel work, and then there's also cloud-based options like Qualtrics or REDCap. Certainly, this is another area where it's worthwhile to check in with your local or state public health agency and get a sense for how they need to collect information from you, how you might be reporting to them, and also what systems they're using. So Philadelphia, for a long time, we've faxed results over, and this summer they'll be instituting a new product called ComCare that will be asked to adopt and to report through as well. So check with your local and or state public health agency, but these are some options available to you directly. Next slide. So information to collect regarding cases. You want things like the test date, their symptom onset, the date of the interview, and that's so that you can run some metrics, and we're going to get into that in a minute. Demographics, and this is going to look different for every institution because every institution is going to have different benchmarks or metrics that they're interested in. Every institution may be doing case interviews and contact investigations for different groups. Some may just be for students, but some may also be for faculty and staff. And then, of course, the activities of the person you're interviewing. Next slide. So this is an example, essentially created in Excel. So you want to give your case a unique ID. You want to collect their name, their test date, their symptom onset. This is a good opportunity to sort of do the first assessment of what their symptoms were. So in this, we used a 1 for yes and a 0 for no, and that's so that in Excel we can do some quick data analysis based on the information we're collecting in the Excel file. That your institution could do this a multitude of ways. We listed other, knowing that the symptoms related to COVID-19 continue to grow. You collect an address, you list the date of the interview, you can do a quick list of activities here, ask about the living situation, ask about sexual or intimate partners. Healthcare worker is always a good one to know about, because that tells you both about the case's risk level for infection, but also their risk to the rest of the population. Date of birth, sex, etc. So all of this, again, may look different at your institution, but this is just an example of one way it might look, and you can sort of use the markers at the top to guide your interview with the case as you sort of type in the information as you go. Next slide. This is an example of the information interview guide that our Philadelphia Department of Public Health gave us at one point. Again, always great to connect and collaborate with your local and state public health agency. For the most part, many of them are going to be thrilled that you may be interested in helping to take on case investigations for them. But they're also going to want to make sure that they're getting the data from you, because local agencies report data to state agencies report it to federal agencies like CDC, and we want to help everybody get good data and not unintentionally be part of the problem of some of the messiness of data. So this form is another potential interview guide, right? You see on the left-hand side, it starts at day -2. That means 2 days before symptom onset, when this case may have been infectious. What buildings did they go into school or for work? Did they have any healthcare visits either at your college health center, or if it's a faculty and staff, maybe they had their annual mammogram during one of these days. Social settings, this has been really easy recently as isolations and stay-at-home orders have been in place, but the social settings, as we know, will get incredibly more important and incredibly more diverse as more states, cities, localities, colleges reopen. Travel, this is one that has changed over time as well. At first, it was only international travel we were concerned about, and then domestic travel, and then it even became, okay, are you leaving the county that you live in? So worth asking about travel method: car, train, plane, Uber, Lyft, private car, all helpful information, especially as you get more information about your cases and are trying to identify common sources of exposure. Food, grocery stores, are they going to restaurants? Are they ordering food in? And then other, are they using gyms that are open? Are they having friends over for gatherings, etc. Next slide, please. So in our previous example of the case, Mr. Fresh Prince talked about having some roommates and a sexual partner. And so we named his roommates Puppy Dog and Kitty Cat. You can see some of the information we collected about the contact. You get as much information as you can from the case, him or herself, and then you may have to do some additional digging or get more information from the contacts directly. You can see on this sheet that we used our conversation with the contact to actually do our first symptom check for them. That's one of the gold standards in case contact and in case investigations and in contact tracing is, can you get information from the cases? Can you identify and notify contacts? Can you isolate and quarantine appropriately? And then, if possible, if staffing capacity allows, can you do regular ongoing symptom checks with those contacts so that you're aware when they potentially convert to a case? Again, in this example, we use the 0 and 1 method just for easy data analysis calculations, but you could do this a multitude of ways. This is just one example. Here also we see that Quaker Oats was a faculty member that Fresh Prince came into contact with. So that will be an additional contact that we will be notifying about their exposure and providing guidance on quarantine procedures. Next slide. So what to assess? So in case interviewing, there's there's a multitude of options. We've linked guidance to the CDC contract tracing principles here. There's also a resources tab in this slide deck that has lots of other links to contact tracing best practices, including best practices for data monitoring and assessment. So this is just a snapshot, but for case interviews, how long does it take from the time of interview, from symptom onset and diagnosis, proportion of cases interviewed, medium number of contacts elicited. All of these are examples of things you may want to collect or may want to assess along the way. Next slide. Contact follow-up. This is related to that symptom check or symptom follow-up piece about tracking conversion of a contact from an asymptomatic exposure to potentially becoming a case themselves. Next slide. Specifically related to staffing, there's actually a lot of recommendations from CDC and they are not all listed here. This again is just a small example, but this can help inform staffing capacity, staff training. What additional information does your contact tracing staff need to be more effective, and more efficient? Next slide. Process measures. What does your institution or your department even need to know or want to know in terms of how this process is working? So this again is a small example of options available for metrics to assess: number of case investigations assigned, number and percentage of clients, students, staff, faculty, whatever it is, who named at least one close contact, medium number of contacts named per patient interview, etc. Next slide, please. Going back to symptom checks real quick, this is just another example of a way you may be able to set this up. You'll have at least one symptom check and then maybe up to 8, 9, 10 symptom checks. It really just depends both on your capacity and on at what point you get connected to the contact along the way. Next slide, please. And then outcome measures. How effective have your case investigation and contact tracing efforts been? So these again are just a small example of the number of things you might be able to look at to assess your success in case investigations and contact tracing. Next slide. An important part of the contact tracing and the case investigations and collecting the data and monitoring the data is being able to identify patterns and responses. So you can track commonalities. Is there a common source that's coming up again and again, like a particular event, a particular location, a particular person? The other thing to think about as a best practice is having a frequently asked questions guide that's available for the staff that you are using to do the case interviews and to do the contact tracing. That may grow over time because as you do more case investigations and more contact tracing, you get more common or frequently asked questions that you can add to that guide. But it really helps empower the staff that you're using to feel like they can answer questions. It also helps keep consistent responses and answers to people's questions. An example of common questions are, how did you get my name? What is my information going to be used for, etc. And again, please remember that there are additional slides in this slide deck that are available to you that we're not going to get to here, but we'll have additional scenarios and examples that may be helpful for you as you set up your contact tracing efforts. Next slide. Back to you, Jason.
Thank you so much. Let's please advance to the next slide. Great. So this is also part of what Governor Inslee released on Wednesday, and I wanted this to be part of my summary because while I'll be talking about case interviewing techniques and contact interviewing, it's extremely important that the public is aware on a broad level that all persons who test positive will be followed up with by somebody in a case investigation or case interviewing or broadly contact tracing role. And it's also important to mention that it was Monday, January 2nd, January 20th, when Washington State made its first confirmed diagnosis of COVID-19, and it was also the first patient in the United States. Since that time, COVID-19 is among the notifiable conditions, which means that any new infection of COVID-19 is submitted to the state public health laboratory and our state health department. And this is happening across the country, again, mostly by way of tests that are administered at drive-through settings and making their way through the local health jurisdiction to the state. And that's important information for anybody conducting these phone calls. And I expect that the same legal code and system is in place across all jurisdictions in the country. So with that, let's just go ahead and advance to the next slide. Okay, so since that time, we have developed a standardized, consistent system for contact tracing, including a process for spacing out a total of, if it takes this long, 4 different phone attempts and associated voicemail messages with text messages to cases who we have identified and contacts in 2 different REDCap flow systems, but at any rate, that's the system that we're using currently before assigning somebody as lost to follow-up. So anyway, that was one of the main points for this. Also, what's important is that since February, we have a protocol for dealing with long-term care facilities, because Washington State was also the first location of a nursing home associated outbreak. And unfortunately, I mean, that's a reality all across the United States today. But a lot has changed that has informed how internally across the state we batch records and address issues at long-term care facilities, and everybody working at long-term care facilities is tested here and in New York State and elsewhere, as I understand it, on an ongoing basis to make sure that they are safe to be at work and keeping everybody unexposed. Next slide. So one of the key things that is going to influence how well trusted you are is your confidence and how well you know the script that you're working through, the questions themselves, and also at the same time being accessible and available. And when John earlier in this presentation used the word safe with regard to how people might feel when they're on the phone with you, and if they're hearing background noises or wondering where you are or anything else, that's extremely important. And let's not forget that there's physical safety and psychic safety, and people are in a lot of stress. At the same time, it is dare I say, a wild spectrum of even the resident at a long-term care facility who is in her 90s and is completely asymptomatic and just aggravated that, you know, they tested her because she lives where she lives, and now she's all by herself in a ward and in a part of the facility where she feels isolated. So and some people really want to talk, while other people are coughing and not comfortable and you know, seemingly increasingly disappointed that there's another screen of questions. Next slide. So how do you make this work? It's important to explain very clearly who you are and why these specific questions are of importance. And again, the goal is to reduce transmission. The goal is to control this outbreak. The goal is to prevent future cases. And your answers to these questions is extremely valuable. So those are a few things I emphasize. We at Washington have had access to it's Language Link is what I believe it is, a resource for interpreters for every language that we have needed so far. And that is available 7 days a week, the same 7-day-a-week schedule that that our teams are engaged in. So that has been extremely helpful, but that will influence, I mean, the experience itself and the data itself and how long it takes and its smoothness. Next slide. So emphasizing that no one is in trouble, we're calling to follow up some clarifying information. I mean, we here at the state are collecting demographic information. We also really want to know well, firstly, what kinds of symptoms an individual patient is experiencing, and that will influence some of how the guidance is delivered. Public health guidance being obviously very key in this, the public health mitigation. And part of that mitigation is also learning what the usual activities are for any of these individual cases and contacts. One of the exciting aspects of this is uncovering similarities, noticing patterns in your probing questions. You know, in the case of, well, the meat packing, food processing, agriculture settings where people are working, as well as other congregate settings. We ask specifically if during a period of time of interest that we have, if you have been to long-term care, adult family, assisted living facilities, places of worship, daycare, childcare, correctional facilities. And one of the things that we did learn was, well, there was this incident or this, you know, this series of individuals that said, yeah, they like to go square dancing on Tuesday night at such and such place. And then that ended up being a surprising and relevant identification of a clustering of disease transmission that was happening. Let's go on to the next slide. Okay, so while going through this, again, being accessible, being available from a non-judgmental place, we want to make sure that we have the right information and all the information. So we're also not answering any medical questions. And through the process of any of these interviews, I find myself, when it gets to the public health guidance, I find myself saying, okay, so we don't have great treatment options. And so what we really want to emphasize is that you as an identified patient case need to self-isolate during this period of time, or you as the household member of an identified case need to quarantine. Well, the reality is that even if there were great treatment options available, we as contact tracers are not in a position to make medical recommendations. So I really wanted to be clear about that. This is a great opportunity, yeah, to provide guidance, public health guidance to stay at home, but also to encourage everybody to be in close contact with their medical providers as well. Next slide. Okay, so when it comes to someone who says, yeah, look, I haven't been anywhere, this is where I repeat the question or rephrase the question. Have you not, have you been to any events or places since May 8th, and they're saying no, no, no. And then I say, okay, so did you not go to any Mother's Day event on Sunday, May 10th? And maybe that's yes or maybe it's no. And then, okay, have you not been to any grocery store since May 8th? And that's where, you know, some additional information may come out of it. Next slide. Okay, so again, psychic safety, we are here to help. All the information that you share is of extreme value to us. If you have close contacts to share with us, I myself will not be following up with them, somebody else will. At least that's how our system is set up. Whoever contacts a contact will not share your information, will not have that available to them. And answering any questions that they have. This is disease investigation. Next slide. Again, you want to answer all of their questions and emphasize, stay at home, mitigate risk. Next slide. Some of these are difficult conversations. So it's important for us to be mindful of that. At the end of this presentation, for those of you who are participating live, and we'll have access to the full slides, there are some excellent resources about what to look for individuals on the phone who may be in situations that are not safe for them to continue talking. And among the symptoms that we are particularly interested in gathering initial information about and then following to the extent that we can is respiratory distress. So keep that in mind. And then for your sake, it's important for all of us that these are not easy conversations and we need to give ourselves space. Okay, next slide. And I'm now going to talk a bit about notifying contacts. Let's go ahead and advance. Great. So CDC just recently updated the criteria for close contacts from a 10-minute threshold to 15 minutes within 6 feet or less of a distance. And I really just try to emphasize in plain English, okay, persons who you may have been close to, coworkers, family members, friends, or others who you have interacted with at a distance of 6 feet or less for 15 minutes or longer, people you have been around. And there's a difference, yeah, between a contact in the community and a household contact. And at that, there's going to be variation. We aren't necessarily collecting all information for all household members. Some of these cases are able to physically distance themselves enough during I mean, maybe their lifestyles are such that they're not in close contact with other household members, and that's fine. And the other point is, in order for it to be a contact, we need to have a first, a last name, and a phone number or some way of getting in touch with them. Let's go on to the next slide. I did want to make a point here that email would not be the way that a state health department is likely to be communicating with a contact, but it is possible in a secure and encrypted way via email to follow up with contacts to make sure that they're okay, that they're safe. Hey, Ashlee, if you have any university, college contacts that you'd like to add?
I think it's just another plug for checking in with your local and state public health agencies. They will definitely have some additional tips and guides for notifying contacts. I know Jason and I had a conversation where Washington State Department of Health attempts to contact people a certain number of times and often will call 4 hours apart. Our process at the University of Pennsylvania is that if we call and no one answers, we actually hang up and call right back. Both of those are examples of ways that you and your institution can try to prove to your contacts that you're not a robot, since you may be coming from an unknown number. But you know, in some ways there are best practices, and in other ways the application of those best practices will look a little bit different at every institution. Next slide. This just goes back to the privacy and protecting the privacy of the people that you're speaking with. So it's really easy actually to not give identifiable information about the case. You don't ever need to reveal where the exposure may have happened or who may have been exposed or who may have exposed them. Only share the date of the exposure and or the expected date for the end of quarantine. And this goes all the way back to the beginning of the presentation where Jason referenced the 3 spokes. A lot of public health agencies are setting up this process to have case interviewers or a team of case interviewers and then a team of contact tracers. So actually the contact tracers who are notifying the contacts don't actually have additional information to share. And that can sort of be a way to help protect your staff or to give your staff more comfort in not feeling in the hot seat with people wanting to know how you got their information. Next slide. John, back to you.
Thank you. So I'm just going to talk about some additional tools that you may have heard about or might be considering. Next slide, please. There is a lot of buzz about location-based apps, and so I did want to touch upon this for a moment. There are nationwide, statewide systems, for example, that link with public health authorities. This is really something we've heard a lot about in other countries, Taiwan, Singapore, South Korea, which also linked their statewide system with closed circuit television and linked it with credit card data, etc., in order to really identify people and those close contacts. But this really is not something that we have here in the United States as far as a consolidated system like that. And I would imagine it's something that links as many things as what exists in South Korea would probably have some pushback from communities here. There are also standalone systems that might be considered for that aren't necessarily linked with public health agencies, and those are potential options as well. Next slide, please. So the way they work might vary. Some apps work differently from others. So you might have Bluetooth low energy or GPS geolocation. If you are using a wireless phone, it might triangulate based upon the network towers. And then for institutions that have a closed Wi-Fi network, there's a possibility of using trilateration, in which your signal strength to multiple routers in the same network would be able to help pinpoint your location. And in fact, this Wi-Fi trilateration actually has been used by businesses for a number of years already. So if you happen to be in a particular store and that store has lots of Wi-Fi routers and your Wi-Fi is on, even if you are not actually connecting to their Wi-Fi network, that network knows where you are if your Wi-Fi is on. And that's how stores figure out which parts of the store are most popular and things like that. So all of these things are out there and exist, but there are lots of challenges. It depends on, for example, if it depends on an app, the uptake and usage of that app can reduce its likelihood of utility. So if only 20% of the people in a community are using that app, then the likelihood that any 2 people who are close to each other are actually captured by this app depends on both people having that app. So it's variable. And there's also the possibility of over-reporting of proximity, which might where you might actually have lower risk, and this could be a problem if you're worried about producing more anxiety than necessary. and what happens if you have two people who are 6 feet apart, but there's a wall between them or something along those lines. So, and of course, in the United States, as I mentioned before, it's unlikely that these systems will report or communicate to public health authorities. And so linkages to the traditional process of contact tracing might not happen. And really, I think the main point is that these technologies are very exciting and may help on some level, but they cannot replace traditional contact tracing as we have already described earlier in this talk. Next slide, please. Okay, so other tools to consider. There are also some symptom tracking apps that are out there that where individuals could potentially put in their symptoms every day, or put in the fact that they don't have symptoms, and that has helped researchers and epidemiologists to be able to identify potential areas or locations and hotspots for infections. It's not really clear whether something like this could also be used for the purpose of contact tracing, but I thought I'd mention that it is out there, and there are some fairly large systems that are available around the country for that. There was a mention of patient portal and how you might use that earlier in the slides. So if you are strapped for staffing and you're unable to do a direct phone call every day for 14 days for every close contact, for example, it's possible that you might use the electronic health records patient portal to communicate with folks in order to complete your activities in an efficient way. So that's an option. Jason mentioned language lines. So these types of services are valuable, and if your health center already has that contract, you could use it. If you don't, it's worthwhile to check around the university to see if some other office has it and whether or not you might be able to leverage that. And then lastly, Doximity is an app that's available that has a dialer feature where you can change your callback number. It's really meant for physicians and people who work in healthcare in order to be able to call patients when they're on call at home, for example. And so you can change the callback number to match the phone number, the main phone number of your health center. And that may be helpful because it won't show up as unlisted when your cases and contacts get a phone call. It might actually say the phone number of your office, and that could be helpful. So I think we're going to stop here and just close by saying that we've covered a lot here, and but you really can't be an expert in contact tracing after just an hour. And so we would encourage you to take a look more thoroughly at all of these slides, as well as the extra slides. And this is going to be just the beginning of putting it all together. And a good portion of expertise in contact tracing comes from the experience of actually doing it. And so at this point, we'll open it up for questions.
Great, thank you so much, John. Thank you so much to all of you for your insight today. There's a lot there. We don't have a lot of time, but I would like to get to a couple of questions if possible. The first one, there were quite a few questions related to HIPAA and FERPA. Can someone, maybe Jason, you could take this first, at least regarding HIPAA, about the role in contact tracing.
I mean, from my role and perspective, the point of the condition itself being a notifiable condition gives us statutory authority to follow up with individuals who are infected and potentially exposed. And so that's what we refer back to as currently written. John, why don't you, if you don't mind, maybe expand a bit on that?
Yeah, absolutely. And so that public health authority, I think, is important to think about. But when universities are doing it, I think it's also valuable for us to view this as a public health activity. At our university, we're really trying to think of broader testing of the campus, if we're able to begin doing that, that it would be viewed as something separate from direct patient care. And so it's really a public health activity. So if we, for example, set up a testing protocol or something like that. And so it's really viewed as public health data as opposed to direct patient care data. Now, of course, sometimes you are going to be collecting samples within a clinical setting. And so there are aspects of the information that should be protected by HIPAA if it is within the healthcare environment. But the fact that someone is testing positive is a public health relevant piece of information. Ashlee, I don't know if you want to add anything.
Just check with your state, because many states have made COVID-19 a reportable condition, and so that gives you a little bit more. That's the piece that you want to go to take it from a clinical piece of HIPAA protected information to a public health matter that can give you a little bit more flexibility in who is doing the contact tracing and what sort of trainings they may need.
Great. Oh, go ahead, John.
I would just add one more thing is that, this is where you want to make sure that you're on the same page with your Office of General Counsel and your privacy officers at the university. So make sure that you engage with them just so that everyone's interpretation is the same.
Absolutely. All right, well, it looks like we're at the end of our time today. Thank you so much, Ashlee, Jason, and John, for a very informative talk. Please stay tuned, everyone, for more information on the ACHA COVID-19 Summit. I'm sure we'll continue the discussion on contact tracing. In the meantime, please continue to share your ideas, questions, and solutions in ACHA Connect. And stay safe and be well, everyone. Goodbye.